So I had this comment on my last video basically saying that statins are useless and that lowering your cholesterol isn't beneficial for your health. So I've got a study here, so let's go into it to see if it is actually true. So the title of this study is The Efficacy and Safety of More Intensive Lowering of LDL Cholesterol, a meta-analysis of data from 170,000 participants in 26 randomized trials. So a bit of context, in terms of hierarchy of evidence, a meta-analysis is basically the top dog, and the reason is that it looks at all these other studies and it tries to draw a conclusion from all of them, and it basically gives you a better overall outlook on what the question is that you're trying to examine. Now, before I get into this, I do want to say that I'm making these as unbiased as possible because at the end of the day, I do want to know the right answer, and I do use statins for a lot of patients on a daily basis. If I find through a lot of this evidence that it's incorrect or there should be other things that we're doing, then by all means I will change my practice. But I do want that to come across that I'm not here to support Big Pharma. I'm not also here to support an ego. I'm here to try and get to the bottom of whatever is correct. So the first thing is to look into who has funded this study. So UK Medical Research, British Heart Foundation, and the actual authors of the study are the Cholesterol Treatment Trialist Collaboration. And I was looking into who they were just to see whether I can actually trust them. And they are meant to be an independent organisation. But however, out of the trials that I did select for this meta-analysis, a lot of the original trials were funded by statin companies or Big Pharma. They are obviously trying to make sure that a study will look good in the eyes of their product. However, these are meant to then take the raw data and they are meant to then obviously independently assess it to then give an unbiased opinion on that. But again, straight away, knowing that someone else has had a bit of an input does sort of put a bad taste in your mouth. So it's just something to bear in mind going through the rest of this study. But let's go on to the method. So how was the study done? So apparently beforehand, they did agree on a protocol, and there were certain criteria that each study that they analysed to fit within this analysis had to meet. It had to be at least 2 years. It also needed at least 1,000 participants. And the main thing was that the original study was intended to look at the reductions in LDL cholesterol, which is where statin therapy normally focuses on, and it is the outcome of what we're trying to find today. Is it beneficial lowering it for one? And the second thing is, are statins actually beneficial in doing so? Or are they actually causing something else that we can't see? So like I said, once the study did meet the criteria, they were then looking at final outcomes. So this might have been non-fatal or fatal myocardial infarctions, which are heart attacks. You've got ischemic strokes, which is the most common type. You have revascularization procedures such as heart bypass or grafts or stent insertions, and they use them as the endpoint to see whether the statin was effective in reducing them endpoints. But as you would expect, because there's so many studies included in this analysis, that they had to try and standardize the reduction in these risks. So they picked it to 1 millimoles reduction in LDL cholesterol. So that is where the headline come from. For every 1 millimole reduction in LDL cholesterol led to about a 5th reduction in these events. But we'll get onto that. Now, these were the studies that were included, and I actually did find something out about this, is there is something called like a weighted mean. And as you can expect, the more participants in one study will have a greater weighting towards the outcome. And that is reflected within the results diagrams, which I actually didn't come across before, or I was never conscious to. So just to break it down, there was 26 total trials that were included within this. 5 of them looked at high dose statins versus low dose statins. The benefits of this is that they are already on statin therapy. So it then asks the question or answers the question, does a further reduction in LDL cholesterol from a relatively low baseline lead to any beneficial outcome? So that is where them 5 trials come in, and the TNT, the ideal and search, seem to be heavily weighted within producing the results for the outcomes. And then the other one was the HPS, which was called the Heart Protection Study, which had over 20,000 people within it. But as you can see in one of the columns here, it will have a lot of abbreviations. So if you go to the HPS, it will say S40 versus placebo. Placebo meaning no statin. And this was the other 21 studies, I didn't explain this, they were statin versus no statin. So the control was basically no treatment. And the S40 is the type of statin, so simvastatin 40, which in relative terms, it's quite a weak statin. It's not that good really. So any beneficial outcomes that come from that study also play towards the statin's hands. But now let's get on to the results. In this table, you will see the top half, which are the 5 trials, which are higher statin versus lower statin. So you can see on the line where it says subtotal 5 trials, it says 0.51 millimole per litre reduction. So that was on average between a low intensity versus the higher intensity. So if you had a 80 milligram dose versus a 40 milligram dose, you would on average reduce LDL cholesterol by a further 0.51 millimoles in the higher treatment group. And you can see in the left-hand column here where it says 3837 and on the other hand it says 4416. They are the total amounts of events that still occurred, and the events that we said earlier, such as a heart attack, stroke, any revascularization procedures, they still occurred on them doses. But you can see that in actual fact there's a 13% reduction, but by the time you do the mathematical unweighted means, it turns out to be about a 15% relative risk reduction. So that did show that despite being on statin therapy, if you increase the dose or go to a more intense statin, it did reduce all-cause events. And that was also mirrored within the statin versus control. So again, subtotal at the very bottom, 21 trials. This was measuring it to about a reduction of about 1.07 millimoles per litre of LDL cholesterol. And you can see, again, there was a significant reduction within this cohort. So when you pair the two together, that is where you come up with the 21 to 24% reduction in these cardiovascular outcomes per millimole per litre reduction in LDL cholesterol. But there's still a few things that I want to go over, so don't just go, yeah. So when it comes to studies, we want to look at how them events come about. So like we said before, there are different types of heart attacks. So you can have a fatal heart attack, which is, as it says, fatal. There's ones where it's non-fatal, where it can just cause debilitation. So the next table goes on to the categorizations of where them events sort of arisen. So just going through the table, non-fatal MI. MI stands for myocardial infarction, so that is a heart attack. CHD, which is coronary heart disease death, or any major coronary event is the one below it. Again, you are seeing a significant reduction within the events in the statin or the higher dose statin group, which is on the left-hand side. And if you go down all of these, so the next one is CABG, C-A-B-G, which is a coronary artery bypass graft, which is the most common form of heart surgery that you'll see. PTCA, which is a percutaneous transluminal coronary angioplasty. Both of these again are to do with the vascularization of the heart. Then you're going into stroke territory. Now the difference between strokes, you've got ischemic, which is usually caused due to a blockage. Hemorrhagic is due to a bleed on the brain. And normally with statins, which is one thing I would like to point out, if you look at these graphs here, there is a higher incidence of hemorrhagic stroke whilst you are on statins. And that is across both the higher intensity one and the statin versus control. There is obviously a greater pathology underlying for the use of statins when it comes to bleeding on the brain. So if someone does have a predisposition to that, then I would be more wary to give a statin. Now, the next part of the study that I wanted to draw attention to is mainly in relation to the higher dose of statin versus the lower dose of statin. And the reason I bring this up is that when you do a lot of clinics, you will have something called primary prevention. So there are two types of ways that you can treat patients when it comes to heart disease or strokes. And you can treat them where they haven't yet had an attack, or you can have them where they've already had an event, such as a heart attack or stroke, and then you are trying to prevent a second event. So primary prevention is the act of preventing the first ever attack. Now, when someone comes in with normal cholesterol levels, we always say, is there any benefit of giving them a statin despite them having a normal profile anyway? And this study did go on to show that even in the group who were treated with low dose statins, so they had a lower baseline LDL, and it was about 2.5 millimoles, which is really low. Because when you compare that to the control group who do not have any statin treatment, they had an average baseline of about 3.7 millimoles per litre. So you can see the difference there. And despite having a lower baseline LDL cholesterol, this graph is actually showing that you will see further reductions in cardiovascular events, anything to do with heart attacks and strokes, despite having that low baseline if you increase the dose to then further reduce LDL, which is something that helped me over the past, I would say 12 to 18 months of my surgeries, because when trying to explain to patients whether I should increase their dose, this sort of guided me along them routes. Now, I am aware of the size of this study, and I will put the link to it below, so you can always look into it. I'm trying to be as transparent as possible because, like I said, I want to try and find the answer out myself too. But on the whole of it at the moment, further reductions in LDL cholesterol do seem to come out with beneficial outcomes with regards to reducing heart attacks and strokes. The only negative at the moment seems to be that it does increase the amount of bleeds on the brain. Yes, not in large enough quantities to really be put off by using a statin, but enough to put it in the back of your mind to definitely think about it, and it's something that I will take forward within my practice. Now, the next graph that I want to draw attention to is the risk of cancers during these trials, and there basically doesn't seem to be a difference between the statin group, higher statin group, lower statin group or control, to be honest. But the only thing that I find quite hard when referring to statin studies, and this is something I will make clear, is that a lot of the people who are on these types of medications in the first place tend to be unhealthy. They do not follow the basics such as exercise, good diet, sleep or stress management. So then trying to draw conclusions as to whether other aspects of their life are having a bigger influence on other disease progresses is hard to remove out, and they are the confounding variables that come into any study when it comes to this area. So even though the risk of cancers didn't seem to change, all-cause mortality apparently did reduce by 10%. A lot of this was attributed to the fact that it was reducing the amount of deaths associated with heart attacks, which you would expect because that is how statins are meant to work. They are meant to reduce the amount of cholesterol produced within the liver. They're also meant to increase the amount of uptake of LDL cholesterol via LDL receptors on the liver. So it does seem logical that that would lead to that pathway. But to summarize, there are a lot of things that are not included within this study that will influence the amount of heart attacks, strokes, a lot of ill health that you will gain within life. So cholesterol is potentially not the only thing to cause it. We are more aware of the role that inflammation plays, especially low-grade chronic inflammation. We have also got the effects of stress. We have also got the effects of high blood pressure, endothelial dysfunction. All of these things do contribute to heart disease, heart attacks, all these things at the end of the day. So looking at one particular aspect is not the way to go. But because of that comment, it did make me look into whether actually any concrete evidence on the use of statins and using higher dose statins. I believe there is to an extent, but because I can't see the raw data and haven't seen the raw data, and to be honest, I will not have the time to go through all 26 randomized controlled trials and go through every single selection and exclusion criteria. But knowing that a lot of the pharmaceutical companies who have produced the statins have had a big say within the funding, yes, you are not meant to be biased, and I keep saying it all the time, humans are inherently biased. It is always in the back of your mind as to whether you can influence these results to make a health organisation, a government, a guideline procedure, all in favour of statins. However, based on this meta-analysis and assuming that it is independent, there is a lot of evidence for using them and to use higher doses. But it will not stop me from advocating for early prevention. Before you even go on primary prevention with a statin, you should include and be maximising the 4 main pillars of health, which is exercise daily, eat real food, sleep enough and manage stress. If you do all them 4 things, you will probably reduce the need altogether to go into a statin and then reduce this idea that you need to go into a debate with a health practitioner. Looking at this evidence, it's pretty good. But I am not naive that there are other papers out there about the adverse effects and other ways that we should be manipulating our risk in terms of heart attacks and strokes. Going back to the comments, which I will put up again, they did say that cardiovascular disease is still the leading killer worldwide, and it is. And I feel like a lot of that is just due to the fact that the majority of the population are having poor diets, lack of activity, and when it comes to cardiovascular disease, the one thing you need to be doing is exercising. You need to make sure that your heart is increasing in efficiency and you are increasing muscle mass, you are increasing functionality, all them things. But if you feel as though there is something else that you would like me to address by going through a study, again, trying to be transparent, then by all means, leave it below. Whatever comment gets the most interest or whatever I find most interesting, I will do it next week in another review. If you've got this far, thanks for watching. As always, it is not medical advice, it's for informational purposes only. I'll put the study below, you can go and do further reading into it and develop your own opinion. But I've obviously gone through my opinion at this moment in time, and hopefully I'll see you in the next one.